Welcome to the Welcome to the CCIH 2022 virtual conference. I'm Mona Bormet, Program Director at CCIH, and we are so glad you could join us today for the conference and our Day on Health Systems. So you will see a slide with instructions on how to listen to the conference in English, French, or Spanish. And so at the bottom of your screen, there is an interpretation button, and we encourage you to press that and to choose the language of your choice. We are very glad you're here, and we hope you could introduce yourself in the chat box and let us know where you're joining from. And if you're new to CCIH, just so you know, we're a global network of approximately 120 Christian organizations and 15 secular partners, as well as a few hundred individual members. Our mission is to promote health and wholeness from a Christian perspective, and we provide opportunities for capacity building, networking, sharing best practices, and advocacy. So we're so glad you could join us today. Love seeing the intros in the chat box. Hope that continues. And we're very grateful for our sponsors who've helped make the conference possible. Today, we're especially thankful to our platinum sponsor, Gilead Sciences. Gilead is a biopharmaceutical company that has pursued and achieved breakthroughs in medicine for more than 3 decades with the goal of creating a healthier world for all people. The company is committed to advancing innovative medicines to prevent and treat life-threatening diseases, including HIV, viral hepatitis, and cancer. Gilead operates in more than 35 countries worldwide with headquarters in Foster City, California. So thank you so much, Gilead, for sponsoring the conference. We'll be hearing more from them later today. Now, just for a few housekeeping pieces, we will hold all questions until the end of today's program, and we'll do Q&A before we move into a time of networking and breakout rooms, which will be at approximately 10:20 Eastern time today. So all the questions that you put in the chat box we'll be collecting. We have staff monitoring that. So please do ask our speakers questions. The session is being recorded and will be posted on CCIH's YouTube channel in a conference playlist. And you will also find links to the recordings on our website, ccih.org, under events. And we hope that you share what you're hearing and learning today, any helpful experiences from speakers on social media. So our hashtags for the conference are CCIH 2022, faith-based, and global health. So look forward to seeing what you all are posting. So now I will turn it over to the moderator for today's session, Barbara Campbell. Barbara is Executive Director of the Dalton Foundation, where she is developing and implementing strategic programs and partner relations to support health system strengthening. Barbara also serves as CCIH's board's vice president and is co-chair of our data and mapping working group. So we're very thankful to Barbara for moderating today's session, and I will turn it over to her. Welcome, Barbara.
Thank you, Mona, and good morning, good afternoon, and good evening to everybody joining us. I hope you are as excited as I am about this session. CCIH has done an incredible job and put together an incredible program for you today. Before we begin, I would love to join us all, start in prayer. So if y'all can bow your heads. Dear Lord, we just thank you for this glorious day, and we thank you for the incredible technology that allows for this event to happen, Lord. We pray for each and every person here. A big thank you for CCIH and all the work they put into this incredible opportunity. I pray for everybody here, Lord, that they may hear what you have for them to hear, Lord. And our ultimate prayer through all of this, may we learn and connect and grow in order to bring glory to you as we serve throughout the world. In Jesus' name I pray, amen. All right, so thank you again, everybody, for joining us on the 4th day of CCIH's annual conference. Each day we're focusing on a new theme related to the loving your neighbors. And the theme for today is strengthening health systems for resilience in times of change. This is a topic very near and dear to my heart, and I hope for all of you as well. As you're listening this morning, I want to encourage you to be thinking about the discussion questions that we're going to talk about at the end today in the breakout rooms. First, we're going to talk about technology. How are we selecting and applying appropriate technologies to improve and build health systems? Number two, health worker training. Are we investing enough time and resources in pre-service and continuing education for health workers, especially to improve holistic care? And number three, conflict in health systems. How are conflicts in places like Ukraine and Ethiopia destabilizing health systems, and how are you proactively preparing systems for conflicts or emergencies? We're going to get started right away, and we're going to start today from hearing from Dr. Nathaniel Smith, who will be speaking with our CCIH Executive Director, Doug Fountain. Dr. Nathaniel Smith serves as Technical Advisor for CDC's HIV Care and Treatment Branch within the Center for Global Health. He is also an internal medicine and infectious disease physician and an ordained Anglican priest. So Doug, I'm going to turn it over to you.
Terrific. Thank you, Barbara, and welcome everybody as well to the conference today. And Dr. Smith, so grateful to have a chance to speak with you today. And let's see, are you here? I can't see. There we are.
I'm here.
All
Thanks,
right,
Doug.
terrific. Nice to see you, and thank you for taking time to meet with us. And I'll just dive right in if I can, because you have a tremendous amount of experience, and I want to give you a chance to share from that. Dr. Smith, resilient health systems is a bit of a buzzword. It has many facets, all of which are important to strengthen and support. Drawing on your broad experience, how do you think CDC is advancing resilience?
Doug, that's a great question. It's also a very broad question. Resilience can be defined in many ways. For the purpose of my answer, I'd like to focus on two key aspects of resilience, which are adaptability and surge capacity. In the global health context, CDC is working to advance both adaptability as well as surge capacity. Workforce development is a critical aspect of that, to advancing both adaptability and surge capacity. And CDC has various training programs to build the workforce, to train health care and health professionals in areas where they need to be working and prepared. The Field Epidemiology Training Program is CDC's really signature training program, and then an adaptation of that, the Field Epidemiology and Laboratory Training Program has trained thousands of national health professionals to detect and respond to infectious disease outbreaks and other kind of health emergencies. And CDC also works with national public health authorities to improve their emergency operations. And we also have what we call a global rapid response team to be able to deploy trained, experienced professionals from CDC to provide timely assistance where it's needed to help with both the adaptability as well as surge capacity. Another aspect of this I'd like to highlight is laboratory capacity. For resilience of our health systems, our adaptability and surge capacity, we need to have labs that can do the things that we need them to do. CDC's worked for decades to build laboratory capacity around the world. As an example of that work and how it's helped in the COVID context, the molecular laboratory capacity developed for HIV diagnoses in Africa through the President's Emergency Plan for AIDS Relief, the PEPFAR program, has been utilized. We've depended on it heavily for COVID laboratory surveillance during the pandemic. CDC's also adapted other aspects of the PEPFAR program in response to the pandemic. For example, moving to multi-month dispensing of medication and providing points of care within the community so that patients don't have to come into crowded healthcare facilities.
Well, it's terrific, and by the way, congratulations to the CDC and really to the entire field on the selection of the new head of global AIDS efforts, Dr. Gilkeson. That's a terrific move, and we're grateful for that. I really want to build a bit more on what you're speaking about in terms of adaptation and surging, and I'm thinking about the fact that we see many challenges facing health systems in crises and complex, protracted humanitarian emergencies. What role do you see that faith organizations and local churches play in strengthening health systems?
Doug, that's another great question, very broad. We could spend the rest of the next several days talking about that, but I'd like to summarize my response to that in 3 words: trust, partnership, and hope. Trust, as we've seen during the COVID pandemic, providing accurate health information and education during complex and rapidly evolving public health emergencies is a major challenge. And overcoming the flood of false and misleading messages makes that work even more difficult. Faith organizations and local churches are trusted members of their communities. They can provide tremendous help in helping to promote truth and countering destructive misinformation. Second, partnership. Faith organizations and local churches have extensive relational networks in their communities, and they can assist in building effective partnerships and local coalitions to respond to a wide range of health and humanitarian needs. For the international faith organizations, they can work with local partners to connect them to grant funding and help them to form collaborative efforts at the national and international level. And third, hope, which I think is the most important. As we grind into this 3rd year of the COVID pandemic, health workers and communities are just exhausted. Whether you call it burnout or moral hazard, the loss of hope is a reality of complex and protracted humanitarian crises. The good news of Jesus Christ is our ultimate source of hope. When the foundations are shaken, where else do we turn? The message of the gospel brings meaning to human history and makes sense of our suffering. And who better to bring this message of hope than the church?
Mm-hmm. The church creates the narrative that helps us be able to explain and make sense out of this world. And I really appreciate what you say about trust, partnership, and hope. Recently, the WHO pandemic team was working on some language, and they came out with some very great language about the role of faith communities in building trust and the role that they play on that. And that's something that we can all build on. I'm thinking about your experience. Really, your career spans long-term healthcare missions to working in state government executive leadership, and now with the CDC, including a stint as the acting director of the Global Health Bureau. So it's quite a remarkable trajectory, but you're also an ordained Anglican priest. I wonder, a lot of young professionals all over the world are interested in how you manage to integrate faith and your technical work in a government agency. What advice would you give to people at different points in their career along that line?
Yeah, Doug, this is a really important question. It's one that is really important to me personally, and I've given a lot of thought to. I think the best advice that I can give to young professionals is to live into and out of your identity in Christ. The work of loving people well, and that includes our public service, is about encouragement. It's about directing people towards the true source of grace and healing. For me, it's that integration of what I do in public and what I do when no one's watching, what I do to build up my colleagues at work, and how I care for my fellow parishioners at church. The love for truth and the love for people flow out of our identity in Christ. They come from the same substance. If we live as the people that God made us to be and redeemed us to be, then we bear witness to the love of Christ in all that we do. knowing who I am in Christ and living out that identity authentically in all aspects of my life is what enables me to integrate my faith and my work as a public health professional. I'd like to expand on that a little bit, Doug. We live in a culture that would like to define the church, define Christianity as really a private, voluntary religious society. And what you do and what you believe and what you say is okay as long as you keep it private and stay in your lane. But we're called to proclaim the gospel of the kingdom. And the kingdom of God is, in addition to being personal, it's also cosmic and it's also communal. And it doesn't have lanes. And so that brings us into fundamental conflict. And if we let our culture, let our the world that we live in, the worldview, the plausibility structure that dominates right now, define who we are as believers and who we are as the church, and what the gospel is, then there's going to be either conflict, or we're not going to be able to truly proclaim the gospel of the kingdom. You know, those who are looking for resources on this, Leslie Newbegin wrote really a great book, The Gospel in Pluralist Society. And if you're going to read one book to help you to live out your faith and understand why it's difficult to do that in a government setting or a non-Christian setting, or even in a Christian setting, where you're constantly feel like you have to stay within your religious lane, read that book. Another great resource, Michael Cohen has written extensively on the missional church, and A Light for the Nations is a good introductory work. And I know we're at time. My last thing is, if you can find a mentor to help you in that, then do that. There's nothing like coming alongside someone else who's been at it a little bit longer.
Great, I really appreciate that. I love the point about integrity. What you do when nobody is watching, that infuses us through our character. And then those books are great, terrific resources. In fact, I think we should get those into the links in the chat here. And really appreciate your thoughts on this. You have a terrific experience. Dr. Smith, thank you for taking a few minutes to expand on these things with us today. Really appreciate your time.
Thank you, Doug.
Thanks.
Thank you, Doug, and thank you, Dr. Smith. I really appreciated that question on integrating your faith in your work and in the context of a government setting. That's absolutely incredible. I don't know about y'all, but I think about these things every single day, and your advice on first living in our identity in Christ is just so valuable. So thank you, Dr. Smith. I really appreciate that. Now we're going to spend a few minutes learning more about our sponsor. A huge thank you to Gilead Sciences for sponsoring today's session of the CCIH Annual Conference. I would like to introduce Dr. Harold Nusser, the head of Global Patient Solutions at Gilead Sciences, who will share a brief message with us today.
Thank you. Hello to all of you. My name is Harold Nusser. I lead Gilead Global Patient Solutions team that works to combine partnership and innovation to reduce the disproportionate disease burden in low and middle income countries. First, thank you all so much for joining me at this year's Christian Connections for International Health Conference. I'm really happy to be part of this conversation, to listen, learn, and engage with leaders in the faith community. We know that making an impact means forging deep partnerships. Without the voice of patients, my video is breaking down, sorry. Without the voice of patients, local experts, public and private sector partners, our work is neither effective nor sustainable. One of our longest lasting partnerships is with the faith community, the Vatican, to be precise, with whom we are working in rural villages in Tanzania to expand HIV testing and treatment to people who live miles away from HIV clinics. As this year's conference theme recognizes, we must work together to overcome the challenges facing us. Gilead not only values partnerships for access, we depend on it. We commend the partnerships that this community is forging and strengthening, even in the hardest imaginable times. Despite the pandemic, our faith-based collaborations continue to thrive. Local Catholic ministries like Our Lady of Apostles and community health providers continue to test and treat residents in the Shinyanga and Simiyu regions. Our partnership has helped test over 112,000 people, treated more than 3,000 adults and children, and helped prevent mother-to-child transmission of HIV for approximately 200 babies, ultimately lowering the community's viral load and slowing the rate of HIV transmission. Another example of endurance is the Rome Action Plan, which Gilead joined in 2017. It is a multilateral, multi-sectoral partnership dedicated to finding pediatric solutions for HIV and tuberculosis, with the ultimate goal of expanding access to HIV and TB medicines, and with that decreasing deaths for children across the globe. And as Gilead evolves, both in virology and into new therapeutic areas, we're looking for new partnerships and collaborations, contributing to health system strengthening and empowering communities. We have no doubt our Christian and other faith-based colleagues will play an integral part in the future of healthcare. We know there's much to learn from this community here. We are here to listen and find solutions to today's access challenges together. Thank you again to all of you for your dedication to global health. I very much look forward for this year's conference to learn about your work and to forge new relationships. Thank you.
Thank you so much, Dr. Newson. I really appreciated learning about Gilead Sciences. I have to admit, I didn't know a lot, and I actually have some questions for you, so I will be following up. But thank you so much for being here today and for being our platinum sponsor. We really appreciate that. Our next presentation, we're moving right along today. You guys are in for a treat for how many speakers we have today. It's absolutely incredible. We're going to switch our focus to technology now, and our next presentation is about how Banda Health uses technology and relationships to strengthen clinics in Kenya. Dr. Stephen Letchford is with us today. He's a trained physician specializing in internal medicine and in pediatrics who moved to Africa in 1998 and in 2016 co-founded Banda Health with a vision of transforming lives by using technology solutions and relationships to empower the clinics caring for the world's lowest income patients. Diana Ayabei is owner of the SpaceCare Health Services Clinic and is a user of the Banda Go software in Kawangware, Kenya. I apologize for butchering the names. I will turn it over to you.
Thank you, Barbara. Next. 24 years of living at mission hospitals has made one thing very clear for Sherry and I, and that is that our poorest patients arrive when it's too late. The child comes in and dies, the mom cries, and you think if they had just been able to come a few days or sometimes a few months earlier, it could have been totally different. But the reality is that our hospitals are just too far away when many of these families need us most. Almost always, though, there is a little clinic within walking distance of where these people live. And that little clinic has been doing the best it can with what it has. Next. Several years ago, SIM helped us form Banda Health, which is a nonprofit now that empowers little clinics using two tools. And those tools are technology and gospel-shaped relationships. Next. The paradigm that we work with is very familiar, and that is whether somebody's rich or poor, it doesn't really matter. Good healthcare is just three things. It's getting the right diagnosis, getting the right treatment, and getting them at the right time. The problem is that when you're poor, that little clinic that you go to almost never has a doctor to help with the diagnosis when it's needed. And that little clinic that you're going to is operating on some very tight financial margins. And so the treatment that you need may not be available when you need it. And when you do get the right treatment, it can be too late, too far away at one of our higher capacity hospitals somewhere. Next. The good news, though, is that these little clinics are literally everywhere. There are somewhere around 4,000 small private clinics serving the poor in Kenya alone. And the vast majority of these clinics are well within reach of the internet today. Across sub-Saharan Africa, there are tens of thousands of these small clinics. Next. Banda was formed as we asked the question, what if we could empower these clinics in the 21st century? What would it take? And this morning, Diana and I would like to give you a little glimpse of two complementary approaches that Banda has validated as we have sought to answer this question. Next. First thing we validated is that clinics in East African slums and villages will use online technology to solve their problems. Our online technology is called Banda Go. Clinics use it, typically with old computers, usually with mobile internet that's everywhere these days in many of the slums and villages. Next. Clinics are using Banda Go to transform their work in a number of ways. One is they use it to eliminate theft because they can keep track of where their money and their medications are going in real time. Second, they can use it to save time tracking down patient records because they can use identifiers like cell phone numbers, who would have thought, when patients show up and can't remember what their clinic ID number is. Third, they use it to access their medical notes quickly without worrying that these notes will have been lost or misfiled or left at the house or whatever. And fourthly, in Kenya, they can now use it to complete a government outpatient report in 5 minutes. And that's a report that used to take them 1 or 2 days every month to complete by hand. So these clinics end up with more time, more resources, more information as they take care of their patients. Next. So we validated that small clinics will use online technology if it meets their needs. But we've also validated that our technology opens the doors for gospel-shaped partnerships that have a synergistic impact. And these partnerships are in 4 key areas right now. First are partnerships that capacity build. They capacity build frontline healthcare workers like LifeNet, AMH, and others. Second are partnerships that streamline access to some improved supply chain options. And Richard, who's here, helped us connect with meds in Kenya. Third are partnerships that help other ministries that are running their own medical outreaches, helping them to maximize sustainability and impact. And fourth are partnerships that address the many social and spiritual issues that are in these communities. Next. So far, we have scaled to 70 clinics in Kenya and Uganda, with one outlier in Niger, and we've helped them take care of almost 400,000 patients in the last few years. We use a build, measure, learn approach to social innovation. And we do that to be sure that we don't just build something right, but we're building the right thing, that we're creating impact by delivering value for the people on the ground. Next. But 70 clinics with today's Banda Go, which is what we call it, is only the 1 mile marker of what looks like it's going to be a 1,000-mile journey. And so our next goals, even as we work to grow the number of clinics that we're working with, are to increase both the capacity of our technology as well as the scope and effectiveness of our gospel-shaped partnerships. Next. Because our team's #1 lesson during these past 4 years hasn't actually been about technology. It's been about how absolutely incredible, tireless, and innovative these frontline healthcare workers are. Diana Ayabei, sorry, Diana, is one of our heroes. She loves Jesus. She loves her neighbors. You can tell she is a clinical officer who runs the only health facility today in Mtego Estate in Nairobi. And I am inspired every week by Diana and her clinic, and I think she knows that, and I think you will be too. But the question is, can technology and relationships make a difference for clinics who are working in very vulnerable communities? And so I asked Diana to capture her experience on video for the meeting this morning. And I'm thrilled that she was not only able to do that, but she's also been able to join us live for the question and answer time that will come up later. So to end, I'd like to finish, and let's go ahead and play Diana's video.
Banda has really assisted us. Banda has made our work very easy. Banda has made you can track the income, you can track the expenses. You can just click in a second and say, this is the patient I have seen last time. I sign up and I'm not regretting, and I am very happy. It is very affordable. I can't even say it is wonderful. So the signing of Banda was so important for us. Signing of Banda was God came true to our business and to the clinic and to the whole team in general. You know, as we reported the sub-county government, and we, for every month, we have to report the data. We have to take the data to the government, what we have done. And you know, it is, you know, the books, we have to write every day. And again, when the patient comes, you have to write that under 5 book and over 5. It's a big, voluminous book. So currently, it is just in a click of a second, and you print and you just take it. Giving the right diagnosis, giving the right treatment that has been done, giving the right data. You know, sometimes you there is one thing I normally say, you have to verify data. So this one, it has been, somebody has verified for you. Once a patient comes, that is it. You ensure when you are taking 500 number of patients to the sub-county, you are reporting the right data. So for Banda, for me, Banda, the technology is working for us so nicely, for the clinic, for the whole team, for the community. And even the community are embracing. They are like, you are losing this technology in this place. And I'm like, yes. Most of these patients, they are also my friends. We make friends once they come. So we do friends. When they come, even we have done something, a change. They are saying, oh, you are doing good. We are happy for you people. We want this place to have a very big facility. So because of this technology, it is really making our work very easy. Both in the reporting, both in income, both in expenses, both in tracking the expenditure of what we have done. So it is I can't mention, it is endless. And may God continue blessing Banda so that they can also assist other facilities apart from us. Yes. First, let me say, having worked and being with Banda has been like good which has come, because if not because of Banda, then we couldn't connect to LifeNet and Meds. For the coming of LifeNet, since the facility when they came, we were very down, and the structure, the way it was, when they came to the facility, it was not in an orderly, and because of their continuous mentorship and continuous telling us what we are supposed to do, we could come up with even the reception which it was not there. We added even a receptionist, which we didn't have, and having other equipments which LifeNet brought to us, that I, as a person, I couldn't afford, like a baby warmer machine, which is costing over 350,000 Kenyan shillings, oxygen machine, which is a dream in a facility like ours, offering services to a low setup. It was like, this is God, and we really thank. Also, having meds, we had applied for meds for quite a very long time. We even went to their offices. We were not given a go-ahead. But after working with Banda, we were in a position with just from Steve saying, would you like working with Banda and try? We are like, yes, for me. In my heart, I was like, oh, Jesus, this is good. I told him, yes. Said, just to try. You see, if you don't want, it's okay. If you want, it's okay. And they gave us a co-aid, and they gave us their catalog, even to order for the drugs. And even the equipment that we received, it was from Meds, and it was wonderful, of the right quality. So working with this technology has made us to work with LifeNet, has made us to work with Meds, and we really thank God, because we see the growth each and every day that we do our work.
Wow, thank you. That was excellent. I just loved the way you started, Dr. Letchford, with the problem of quality care close to home and how that can really impact lives. And then you spent the last 10 minutes, 12 minutes showing an incredible practical way that you are using the gospel, everything in your faith, everything in your knowledge to bring about the practical changes. And Diana, just a beautiful job of sharing how this work has impacted your clinic. So thank you all so very much. I really appreciate that presentation, enjoyed it very much, and I hope y'all did as well, seeing how Banda Health is helping the people there in Kenya. So we're going to move on to our next panel, and we're going to switch and start talking about workforce development a bit. Our next panel is entitled How the Health Workforce is Driving the Future of Care. And we're going to hear from 3 separate groups. The first part of the panel will feature 3 speakers. We have Yasmine Vaughan. She's the Technical Advisor for Global Health and Missions at Helping Children Worldwide. We have Dr. Aruna Stevens, who is the Chief Medical Officer at Mercy Hospital in Bo, Sierra Leone, and Dr. Gary Gilkeson, who is a professor of medicine at the Medical University of South Carolina, where he is the Associate Dean of Faculty Development for the School of Medicine. Their presentation will show how local medical providers are working in rural communities in Sierra Leone to improve provision for quality medical services. I believe we're going to see a video.
My name is Yasmine Vaughan, and I'm the Technical Advisor for Global Health and Missions at Helping Children Worldwide. Helping Children Worldwide has partners with Mercy Hospital in Bo, Sierra Leone. For 15 years, despite Ebola and COVID-19, Mercy Hospital has been open, treating roughly 10,000 patients a year. The hospital is run by Dr. Aruna Stevens and his cadre of midwives, nurses, and community health workers. We believe at Helping Children Worldwide that it is our job to link resources to needs. Therefore, Dr. Stevens and his staff work with organizations across Sierra Leone and receive support and training from medical providers worldwide. Over the years, we have learned what does and what does not work when it comes to linking providers in high-resource and low-resource communities. Above all else, we believe that the most important thing is strengthening the local health workforce and ensuring patients receive seamless continuity of care. I hope you enjoy hearing from Dr. Stevens and Dr. Gary Gilkeson on how their connections have impacted healthcare in Sierra Leone.
I am Dr. Aruna Stevens, the lead clinician and medical doctor in charge, Mercy UMC in the southern region of Sierra Leone, West Africa. Since 2007, Mercy has been administering quality healthcare in Bo and has extended its services via outreach clinics to 55 villages surrounding Bo. The maternal mortality rate in Sierra Leone is the highest in the world, with 1,360 mothers dying in every 100,000 live births. The mortality rate of neonates, infants, and children under 5 are also among the highest globally, at 34, 82, 111 deaths per 1,000 live births, respectively. These staggering figures represent the real and pervasive challenges women and children face in Sierra Leone with poor healthcare practices and substandard and ill-equipped healthcare facilities. Many of these deaths are preventable if managed timely by skilled health providers.
Interactions between myself, MUSC, and Mercy began as we were investigating the kind of genetic and environmental differences, similarities between people of Sierra Leone and the Gullah population in South Carolina. When I was over there participating in that, we first ran into folks from Mercy and became interested in their mission and bringing that back here to MUSC. There was great enthusiasm for continuing such a relationship and providing medical equipment and medical supplies to Mercy, just as a kind of a sign of the mutual friendship and collaboration.
Mercy Hospital collaborate nationally with local partners like the District Health Management Team of the Ministry of Health and Sanitation, other United Methodist Church hospitals, RHCI, which is the Rural Healthcare Initiative, and other healthcare organizations within the districts. So the services provided by us to the community meets the needs of the people so that we do not duplicate our interventions for the communities we serve. Hospital is a good thing that we always anticipate. And as a nation, we are under-resourced with numbers of trained physicians and clinicians. Thus, having foreign clinicians in our midst to provide healthcare services is a boost to our healthcare service delivery. Visit medical teams from the US and other places have on many occasions trained local healthcare clinicians with skills needed to provide quality healthcare delivery. For example, sonographers have trained many healthcare workers on how to use ultrasound scan for pregnant women to detect early signs of obstetric complication, thus reducing maternal mortality compared to what we have in 5 years. Teams with surgeons do not only perform surgeries, but also have helped in the training of medical students and clinicians with new modernized surgical techniques. Recently, Dr. Gary Gilkeson from US helped me review a pregnant woman with multiple gestation but at risk of pulmonary embolism. His experience and clinical acumen help us as a team to recommend a safe mode of delivery for the patient. Goodwill clinicians or health workers who wish to visit and make change should endeavor to be familiar with management of tropical disease, as they are a major disease burden in Sierra Leone. Also, they must be willing to work with little or no resources, and we must rely on their clinical acumen to make diagnosis, because laboratory investigations are very expensive and not every patient can afford to pay for their labs on time.
Malaria or something, that's a different story, but as hypertension and diabetes and other diseases are becoming more recognized, having an in-place facility that does follow up and does monitor care is a much better way of dealing with chronic medical illnesses. And being able to provide medications on a constant basis is a much more effective way of impacting health.
All right. Thank you so much, Dr. Gilkeson. Thank you so much for that introduction, Yasmine, and great to hear from Dr. Stevens right there on the front lines of the great work being done there in Sierra Leone. I absolutely love to see how you are using the knowledge and gifts, that you've been given here, Dr. Gilkeson, to share that so directly with those in Sierra Leone. I just think that was a beautiful example, and I thank you all for being here, and I thank you all for the wonderful video. I do encourage everyone to keep putting questions in the chat. There is a dedicated team behind the scenes that's aggregating the questions, and we will do our best to answer them all at the end. If not, we'll connect and follow up afterwards to get everybody's questions answered. So please continue to do that. And we are going to move on to the next part of this panel that's on health workforce development. And this is going to feature Lisa Ailaniello, who is the director of the Center of Global Nursing Development for the Medical Benevolence Foundation. And Lisa will be presenting with Philemon Mulenga, who is a midwife and works as a pre-service training officer at the Christian Health Association of Malawi. Together, they're going to share how 8 mission nursing schools in Malawi and Kenya have adopted and adapted an e-learning system to help students continue education despite COVID-19 related school closures. So I'm going to turn it over to you, Lisa and Philemon.
Thank you. Thank you for having us today to speak to you on the impact of e-learning at mission schools in the COVID area. My name is Lisa Ailaniello. I'm the director for the Center for Global Nursing Development, working at MBF. I'm excited to be here today with Philemon Mulenga, a registered nurse and training officer for the Christian Health Association of Malawi, to discuss virtual learning and its impact on strengthening the health system for resilience in times of change and uncertainty. Next. I've used an acronym SBAR to describe the situation in Malawi during COVID, the background of the project, the assessment, and lastly, the recommendations. Looking at the situation at the time, as we all recognize, 2020, COVID-19 forced the closure of nursing schools globally, leaving for a very uncertain future for the financial survival of the programs and the immediate halt of education. Graduations and classroom instructions were delayed, and schools were looking for solutions to keep students enrolled and to continue revenue. The Center for Global Nursing Development works in multiple countries, but chose long-term partners with multiple nursing schools in Malawi and Kenya to implement a virtual learning platform to help programs not only survive, but move into the 21st century with innovative strategies for education. The background, we first started looking at virtual platforms and introduction of a hybrid approach to education in 2019. And COVID-19 provided the impetus for all parties to push forward and make it happen sooner than later. As I mentioned, the Center for Global Nursing Development has 9 partner nursing schools in Malawi and Kenya, which impacts over 2,500 students. They offer a mix of diploma and degree programs in nursing, but all had only used the traditional model of in-classroom instruction. Moving to assessment, as we all recognize, there's a global shortage of nurses, which impacts lower resource countries most severely. The need to enhance and strengthen the education platform to ensure a strong, competent workforce is paramount. Nurses in developing countries account for 60 to 80% of the frontline workforce in healthcare. Next. The current state in these countries makes for challenges on how to best integrate e-learning into their programs. We wanted to introduce a highly rated open source e-learning platform that would be open the door for enormous potential to increase access to world-class curriculum and resources for schools. We chose the Moodle platform because it's the most widely used platform in the world and has depth of expertise and resources available. It was also the virtual learning platform that most faculty had some familiarity with and provided some comfort level moving forward. We recognized there was a need for fast-track implementation and an urgency to onboard faculty and students with training to resume classes. Next. The Moodle platform was able to be personalized and branded for each school with needed privacy and security already built in. We chose a provider out of South Africa as a hosting site to ensure quick access for onboarding training with 24/7 technical support to both faculty and students. This allowed for fully remote learning as needed in situations like the pandemic and blended learning moving into the future. The ability to have a mobile app for students to work offline was also an important factor. Materials could be uploaded from the cloud when the student had internet access and worked remotely offline to complete assignments when internet was limited or not available. The program alerts students to new assignments, deadlines, forum posts, and ability to send direct messages to their instructors. The ready-made course templates helped with ease of content creation on the platform. Next. The current status, 9 schools are currently up and running with expansion plans for 15 additional programs in the near future. The key takeaways: change is difficult, so leadership and key stakeholder buy-in is absolutely necessary for success. Technical support and professional IT support is necessary to build comfort and expertise on the platform, and identifying team leaders or super users for peer-to-peer mentoring was essential to building success. With that, I'd like to introduce Philemon Mulenga. He's a registered nurse in Malawi and a true champion for virtual learning, working with the Christian Health Association of Malawi, also known as CHAM. We first met when he was a lecturer at Nakoma Mission Hospital, or College of Nursing, and he was a true leader there, implementing the virtual learning platform at the Nakoma College of Nursing. He has since taken a position with CHAM as a lead trainer for virtual learning to ensure success and utilization of the platform moving into the future. The collaborative partnership has been key to successful implementation and expansion plans for the hybrid education plan in the country of Malawi. And with that, I'll turn to Philemon Mulenga.
Thank you so much. Thank you so much, Lisa. So it all started whilst I was at Nkoma, and it started with 3 schools, and that was with the support from MBF. Now, moving forward, that I'm now at CHAM, which is the mother body of all the Christian nursing schools in Malawi. CHAM is there now to provide the overall oversight in curriculum implementation, and with such, it has developed an e-learning strategy that it is implementing. As you can see, it has got a vision, strategic aim, the goals, the strategies, the implementation plan, as well as the M&E. Next, please. And the strategy also comprises of goals that CHAM has devised, and these goals are surely into all the implementation and the successful expansion of this e-learning. And the goal number 1 is there just to supplement what Lisa already said about the Moodle learning management system, which provides the quality as well as the convenience to the students. Goal number 2, we want to bring in all the higher learning institutions that are dealing with the health sector, like College of Medicine of Malawi. Goal number 3 is about infrastructure, and this includes the stability in the internet as well as the gadgets that may support the learning and teaching. Goal number 4 is about the e-model that CHAM has put in place, and this e-model is academically led, and we call it academic staff lead. Goal number 5 is to ascertain the quality of education at all levels where assessments and evaluations have to be done. And goal number 6 is to ensure that the colleges are encouraged to do research and use the e-platforms in increasing the research activities. Next, please. So CHAM, in collaboration with MBF, it has seen that in its oversight role, it is looking after 11 colleges. Of these 11 colleges, 4 of them have already rolled out the e-learning, which include Nkoma, Mulanje, Ikwendeni, as well as Holy Family. And with the help of MBF, CHAM is looking to expand this successfully to the remaining 9 colleges that are there under the Christian Health Association of Malawi. With this, thank you so much for listening. Thank you.
All right. Thank you so much, Lisa and Philemon. I was just sitting here and just listening, and I'm soaking everything up. And as if anyone knows me, they know that this whole topic today is like my absolute passion. And I was just struck by, first of all, your presentation there. It was showing how you're using technology to develop the workforce. So you're covering 2 of our, our key topics today. And I was just thinking about how this is all being led by the body of Christ, and how much impact, I think we'll never know this side of heaven, but all the impact that all of the organizations and all the work you're doing in saving lives, in preserving lives, and in spreading the love of Christ. I mean, I just feel like the theme of loving your neighbor, you guys are just showing it so well, and using all the gifts that you've been given to share and help others. So anyway, I just had a moment there while you guys were speaking, and I just wanted to share that, and I apply that to everyone. I think the work is just absolutely incredible. And we're going to go ahead and move on. Keep putting your questions in. I know we're getting a lot of great questions, so thank you. The third organization sharing today under the topic of health workforce is represented by Dr. Timothy Nunn, who is the medical director at Cure Ethiopia and the Ethiopian Orthopedic Program Directory with the Pan-African Academy of Christian Surgeons. So we'll turn it over to you, Dr. Nunn.
Thank you very much indeed. So Cure as an organization is a network of 8 Christian mission hospitals. They're all charity children's surgical hospitals. And our hospitals in Kenya and Ethiopia host training programs, as you've mentioned, with CSICH and PACS. But we also host national resident trainees from the government orthopedic training programs, such as the Tekorambesa Hospital. Next slide, please. So the background in Ethiopia, of course, as many people know, the last 2 years, the national health institutions in Ethiopia have had to cope with 2 significant problems. The first being the COVID-19 pandemic, and the second, the national conflict in Ethiopia. And this has stretched our resources in Ethiopia on the national scale, financially, in terms of manpower, womanpower, and administration. And a lot of our ex-trainees treating wounded people, but also involved in planning, organizing, sorting logistics, distributing resources, and now rebuilding facilities that have been destroyed. And these are all skills that we didn't really train them for in our orthopedic curriculum. Next slide, please. So the question for me was what aspects of their training was actually helpful, and what aspects could we actually add in their training? What skills could we add to that training to enable them to be further prepared for what they had to deal with? And the skills I'm thinking about are management, leadership, ethics, research, and training. Next slide, please. So we conducted a simple questionnaire of methods, simple method questionnaire on a mixed group of residents and consultants, and asked about whether they, during their training, whether they underwent any of these training, these non-technical training aspects, such as leadership, administration, training, research, and ethics. And we collected 50 responders. Next slide, please. The results were that all of the specialists cited leadership, training, and administration and research as areas that they are currently engaged in. 9 out of the 10 specialists stated that there were significant ethical problems affecting their workplace, such as patient prioritization, end-of-life care, and use of scarce resources. And 7 out of 10 had no formal training in these non-technical skills, and 3 had formal research skills, but none of those had medical ethics training residency. New slide, please. So the selected comments about ethics training by specialists were that some had had ethics training as undergraduates, but not in residency. They wanted a good course, and one comment was that it should be set up with patients as the beneficiary, not practitioners. Next slide, please. So the results for residents was that the majority saw the need for a training the trainer course in residency. Leadership, research, ethics, and management were near unanimously seen as needed. Next slide, please. So these are some selected comments about ethics training from residents. And I think the bottom two are probably the most salient. So, and encompass the rest really. So ethics of the whole person medicine is needed here, and violating good ethics is hurting patients. Next slide, please. So in conclusion, the non-technical skills are perceived as not formally taught in residency programs and is seen as a huge gap and training need. Clearly, some of these skills may have been imbibed in the hidden curriculum, but I think a formal process is needed and wanted. These skills would be used in the workplace. They would be necessary as part of a holistic training experience. They would be likely to have significant benefits to patient care and health systems, and would be relatively low tech and low cost to introduce. And I'm going to leave with a question for me and maybe for the audience is, what are the best ways of helping to deliver on these unmet needs? Thank you.
Thank you so much, Dr. Nunn. I'm taking notes as everybody's talking, as I said, because I'm just so interested in this topic, but I really just was encouraged by the study you've done, and it just validates so much of what we've seen in our work for the need of these non-technical skills and how valuable they are in the success, whether you're talking about a successful surgery program or a clinic, and how sometimes we take for granted the fact that we're taught these in our programs here and they're not taught elsewhere. And I really appreciate and I'm encouraged by this work. And I was really just encouraged, again, just thinking about this whole panel of how we just touched on different aspects of workforce development, from clinical training to training future workforce, and to developing these soft or non-technical skills. I thought that was just CCIH, great job of putting together a really excellent discussion on this topic of workforce development, which is so huge for healthcare as we go into the next decade. So thank you very much, Dr. Nunn, and all of our panelists for sharing these just great examples today. I really, really appreciate it. We're going to go on to our next panel, and I don't know if everyone's heard about it. I sure hope everybody's heard about CCIH's 30 by 30 Health Systems Strengthening Initiative, the idea of strengthening 30 healthcare systems at least by the year 2030. And it's an incredible undertaking. I know our organization and our work that we do in Haiti is a part of it. And it's just a really, I don't know, I love mapping. Everyone knows that I love mapping, and just seeing how they're doing this around the globe and trying to measure and quantify the impact that Christian healthcare organizations are having. I think it's absolutely incredible. So now we're going to hear a little bit more about CCIH's 30 by 30 Health System Strengthening Initiative. We have with us Kate Long. Kate is a research associate at the Human Flourishing Program at Harvard University and has worked extensively with Father John and the St. John's Medical College and CCIH as an advisor on the 30 by 30 initiative. And Kate also serves with me on the board of CCIH. And Kate today is going to interview Father John Varghese, who is the Associate Director of St. John's Medical College Hospital in Bangalore, India, and is also a professor and head of the Department of Hospital Administration. St. John's is one of the commitment makers in CCIH's 30 by 30 healthcare initiatives designed to strengthen healthcare systems. So we'll turn it over to Kate and Father John.
Thank you for joining us today. My name is Kate, and could you just tell us your title, the work you're doing in Bangalore, to help orient where you are in the world?
Thank you, Kate. I'm right now in India. I'm working in Bangalore. This is a national medical school, which is called St. John's Medical College. And I'm looking after the hospital. Practically, I'm the administrator of this hospital, which is about 1,500 beds now. Shortly, in a couple of months, it will be 2,000 beds.
Wow.
So we have nearly 4,500 employees here. And we have a medical school, nursing school, and a research institute in this campus.
Yeah. I've been to this campus. It's actually amazing. So tell us about your project, what you're doing.
Well, the commitment we made was to empower the mission hospitals in India in terms of their material management, the procurement, stores and inventory management of the hospitals. So we had a couple of items in our agenda. One was to train the manpower, existing manpower in the hospitals, so that they would do it more systematically. And the second agenda was to have 10 hospitals every year identified to have more deep involvement there, and then make it stronger in terms of the procurement management.
Mm-hmm. Mm-hmm.
So due to COVID situations, we, as like any other persons, could not do much. But to be honest, we could do the training part very well. So we used the online platforms to reach out to the hospitals. And we had collaboration with the Christian Medical Association of India and the Catholic Healthcare Association of India also, and Emmanuel Health Association. All those network organizations were our channels through which we identified the potential candidates. And in a batch for training, there were about 40, and we finished the third batch now.
Wow.
So nearly 100+ people are trained. The basic training is given to all of them. Kind of participatory learning, we just were giving some presentations, and then we're involving them mostly about to share whatever is happening in their hospitals.
Mm-hmm.
And that sharing also has contributed to empower each other for our little practices, because most of these are smaller hospitals where the practices were born and developed and not scientifically imparted knowledge. And therefore, that also we were trying to understand how good they were doing.
Mm-hmm.
And we were feeding also them scientific techniques.
Mm-hmm. Mm-hmm. Yeah, I think it's a really, that takes the learning to a new level when you can see it and be in discussion with other leaders who are facing the same challenges you're facing, but have maybe come up with different ways to approach the challenge. That's a rich part of the project. And what's a highlight for you? What's something that when you look back at the first, phase of this project, what's something that you say, this went really well, maybe surprisingly well? And then what's something that you say, okay, that's a lesson learned, we're going to try it differently going forward?
Yes. I think what we learned from the field is that there is a lot much to do with respect to material management in the mission hospitals. The field is practically green field, because we have hired people who are available in the local,
mm-hmm.
and they are not at all trained in this field.
Mm-hmm.
But over a period of time, they have gained something by practicing and so on.
Mm-hmm.
But if we impart on them some kind of systematic learning, certainly they will pick it up. Okay. And that will certainly contribute to the cost curtailment for the treatment of the poor patients who come there.
Mm.
And we can have better systems so that there will be more effective negotiation, better utilization of the resources, and proper management of the inventory. A lot of wastages and unnecessary time, storage spaces, all those can be served. And they are trainable people. That is what we understand. They are trainable and they are open to learn, but they're looking for someone to train them.
We talk about 30 by 30. The big goal is that over a 10-year period, we at CCIH are trying to showcase and summarize what all these different Christian institutions are doing around the world. Where do you hope that St. John's will be by then?
One thing I identified in this context is that many of them are not IT savvy, and their computer literacy is little low. And even if they are using computers, it's mostly Excel and so on. So there need to be some good solutions some software and so on. There's a point which I have in my mind when I talk about this, because the country has insisted through its policy that the National Digital Health Mission, that all the hospitals across the country have to be linked through network, and they have to share the data of all the patients being treated. And patients will be given unique health ID. By using that, they should be able to avail treatment anywhere in the country. So it's already in place in many of the developed countries, I think. So that kind of a system is being visualized by the government of India.
Wow.
And the government sector has gone far ahead of us in terms of this digitalization. So therefore, I feel that we can benefit from this in two ways. One is that anyway, we have to be part of the National Digital Health Mission. Otherwise, there is a chance of getting thrown out. So we have to be there. And of course, when we have better computer and network systems, we can integrate all the functions of various hospitals in our network, so that we can have better negotiation in terms of purchase. We can avoid the middlemen, and we get to know what exactly is happening in the different hospitals. So when we negotiate on volume purchase and so on, it would be easy. Whether it be CMAI or EHA or any other network organization, they can have more centralized data coming to them, and central purchase systems or common platforms on which they can bring all their hospitals together. Many of our hospitals are facing challenges. Foreign currency or foreign transactions are being strictly restricted. They are not allowing us to continue with that. Therefore, maximizing the capacity of the resources within the country or within our mission hospitals, and then networking and collaboration is the only way forward, I think.
The 30 by 30 is almost a chance just to meet, to go on field trips, so to speak, meet other organizations who are taking different parts of the challenge, or maybe a very similar challenge, and approaching it in a way that makes sense in their context, and that learning and that sense of we're not doing this alone. So our struggles in this part of the world might be very similar to struggles in another part, or very different, and we can support each other as we go through those challenges together. So thank you for what you're doing across India, and especially in Bangalore. And thank you so much for being a part of 30 by 30 and taking the time today.
Thank you. Thank you for the encouragement we get from all of you, especially being part of the CCIH. It's itself is a great matter of great joy that we get continued mails and support and queries, and then kind of mentoring from their side always. So I feel like I'm part of a global community, which is there to support me always and which understands me. So that gives me an inspiration to make or replicate that in my country. Because in my country, the local situation and the challenges we only know. So we have to be more kind of accommodating everybody, understanding them, and try to empower them. Thank you. Thank you, CCH, for being with us and supporting us so strongly.
Okay, God bless you, Father John.
Thank you.
Well, thank you so much, Kate and Father John. I really enjoyed hearing that example, one example of 30, and I think there might even be more than 30 now. I don't know for sure, but of how CCIH is helping to support and aggregate these 30 health systems globally. I think, Father John, at the end, I loved what you said about how we are all, it helps you feel connected to a community. And as I've been doing this work for over 12 years now, I've noticed that sometimes that's one of the main things we can do, is just to encourage and support and let everybody know they're not alone in the work they're doing. And that's why I love this 30 by 30 initiative, and how we can share what's going on in different countries, and how we can encourage and support and learn from each other. And as I always say, telling the world what the Christian healthcare community is doing and the contributions that we're making. It's really quite remarkable. I find it quite encouraging myself, so I hope everybody else does as well. So thank you again, Kate and Father John. I really enjoyed hearing about that. All right, now we're going to move on. I told y'all this was going to be a jam-packed day. I was telling them as we started, I've never seen such an incredible lineup of people all crammed into like a couple hours, and everyone's doing an incredible job. So I'm just privileged to be a part of it. So we're going to move on to our next panel. We have a panel that's going to discuss how we can keep supply chains resilient, even during emergencies, even during crisis. How can this be done? This panel today is going to be moderated by Richard Netchi. He's the Executive Director of the Ecumenical Pharmaceuticals Network. Mr. Netchi will be joined by Siona Piri, the Manager of Storage and Distribution at the Church's Health Association of Zambia. And they will also be joined by Joseph Rugut, a biomedical and renewable energy engineer with the Christian Health Association of Kenya. And we really look forward to hearing your experiences. I'll turn it over to you.
Supply chain has been disrupted during this pandemic, and this has affected our efforts of improving and strengthening the church's health system. But it has also been an opportunity of ensuring long-term stability and efficiency of our church health supply chains. Joseph and Saona will share with us how their organizations, CHAS in Zambia and CHAC in Kenya, have been able to keep the supply chain resilient in this time. So Saona, can you tell us how in CHAS have you been able to improve your capabilities to procure supplies and medical devices and equipment during this last pandemic?
So I'd like to start by saying that in times of emergencies, what we require mostly is a prompt response and action that results into fast results that are needed. So of course, because the nature is that of an emergency, definitely it leaves us within sufficient time for us to invite for competitive bids, and that's what warrants us to adopt a simplified method or direct methods for procurement, just to make sure that we get the intended results timely. Needless to say, when we're implementing these strategies, we need to have a written justification on hand, so that in the future we fall back on it to show why we didn't follow the default procurement methods. So in CHAS, what we did was to identify a focal person that was going to coordinate the response to ensure that all necessary tools or PPEs that were required were identified, and also to help expedite and improve data collection and aggregation for the specific COVID-related items, for indeed the initial supply and resupply of the commodities. Then also to ensure that the response was done timely, we looked at our supplier database, which is able to give us suppliers that we know, and we know that they are reliable and will be able to supply within record time. And also just to mention that in this time of COVID, or in the time of COVID, most of the emergency supplies were procured from local suppliers to manage the lead time. Then I think that was our immediate response. Then just to ensure that our supply system is resilient in future emergencies, we have come up with a plan. We have put a plan in place that will help us identify any anticipated emergencies, and also recognize the affected populations and potential needs that we might require. Then This plan is costed, and we have also mapped it with the shortlisted suppliers.
One of the challenges we had during the pandemic is the supply of oxygen, which became a precious commodity. And I would like to know how has CHAC been managing the strength and managing to strengthen its availability within your CHAC health facilities?
I will highlight the area of oxygen in terms of oxygen generation equipment, the oxygen supply chain, and the oxygen therapy to the patients. So in that season, many things were at standstill. We could have procurement methods that could work, but because of what we call lockdown, that was limiting movements, and it was limiting not only movement but also personnel. There was that issue of people having that attitude of cross contamination or cross infection. So there was that stigma of people going to handle any supplies that you could have ordered. So we also had a challenge of convincing people to go and package what you have ordered and send it to you. So once those were streamlined, especially in our communication facilities, another challenge also came up, and that was a major challenge of oxygen cylinders became scarce. You could want to get oxygen to facilities or areas where people were being isolated, but there was no cylinders to fill at the filling centers. So we realized that in terms of assisting these major emergency departments, our work here got into a partnership with some organizations, and one of the ones that we managed to partner with is Emergency Medicine Kenya Foundation, and we were able to put what we call a manifold oxygen system that we installed piping and put outlets, and those systems could hold about 7 or 5 or 4 cylinders at a time. So it gave us a breathing space to maybe have people to reorder oxygen. For people who are willing to get the oxygen concentrators, the shipping system from wherever they were being sourced from overseas or factories, the challenge of shipping became also a difficult thing for us. So we realized that it is good we increase this piping of oxygen to most emergency departments. So for the issue of oxygen and reaching our facilities, it was also something that we only could encourage our medical supply chain, which is called METS, to assist in the equipment that we use to detect, that is the pulse oximeters and the personal protective equipment, so that staff could work and go to their offices to order the things that are related to therapy and saving lives during the pandemic.
Complete the question. How have you seen, when you started supplying your own oxygen to the facility, was that an added value to the way of CHAC work with the facilities? And also, how about the affordability of the oxygen?
So this is a great question. Most of our facilities are that put up the oxygen generators. It was just a question of electricity being available, and also being able, some were able to fill their own cylinders to the extent of distributing to smaller facilities or the emergency, like the ambulances. So with those ones, they were able to cover their own needs. But now,
what's the biggest challenge you faced during this process of adapting your procedures and also procuring drugs from medicines from your suppliers?
Of course, because of the demand that was increased for PPEs, we noticed that the market had very low stocks, and at times the turnaround was quite long. Then also due to the increased demand, what we were facing were increased prices. Yeah, so that was also another challenge. So to help mitigate this, we widened our supplier base just to ensure that we were in contact with a number of suppliers, and at least we were able to get value for money, because with having a number of them, we were able to compare the prices and come up with the lowest bidder, of course, whilst ensuring the quality of the products that we were procuring. I have learned from the pandemic is that we have to be, first of all, let me say, we have to be ready for emergency situations, and we need to have a committee in place to strengthen the communication, because communication is very key in responding to emergencies. And if you do not have like a coordinator or a contact person, you might just be going round circles. So for me, one of the most important things in responding to emergencies is communication, and also ensuring that you have open communication, both internally and externally. Externally implying that we need to be in constant touch with our suppliers, just to be able to negotiate for emergency deliveries. In this case, whether they require an upfront payment or not, we should be able to negotiate with them to deliver even before the payments are made. This is in order for us to ensure that we're able to deliver to our facilities that we are supporting. Because you find that if our communications or our relationship is not maintained, we will fail to respond in good time.
Unity, or being one, being of one mind with the other stakeholders, because the church is big. It involves very many. We call them very many groups of gatherings or congregations. But in church we are one. We are supposed to be of one faith, and so we also realize that we need to be learning each other's strengths. Within us, there are hospitals which have power to produce their own oxygen, and others cannot produce oxygen. And so that networking, so that you could know, between us, it will not be like procurement, like, you must produce an LPO or must produce an upfront payment. It's partnership and networking and leaning on each other's strengths.
The church has been for a long time working in very difficult very difficult situations. That's why most of our facilities are located in various difficult to reach areas. And I think from these experiences, the church has been really able to respond also to the emergencies. And our supply system, I can say it will even be more strong after this pandemic, because we have been able to adapt our procedures, our supply system, our teams to this challenging time. Thank you for your insights, and have a good day.
Thank you so much to Richard, Sayona, and Joseph for this great discussion on the importance of supply chain. I think probably every single one of us on here can relate to the supply chain challenges and the crunch that we've felt over the past couple of years. And I don't know about y'all, but I feel like it's probably not going to drastically improve. So hearing how practically people are adjusting and adapting, and I know that when we feel the crunch here in the United States, that the impact and the pain is worse elsewhere. And so appreciate hearing how you guys are adapting and working through this. Thank you again for being here today. All right, we're gonna keep moving on. Thank you guys again. Our next panel is on strengthening community systems. And our first speaker is going to be Esther Kuhn, who's with World Renew as Senegal's country director. And thank you, Esther. I'll turn it over to you.
Thank you, Barbara, for the introduction. Yes. So let's dive right in. Next slide, please. So I'm going to present to you the Adolescent Health and Rights Program. Can we go to the next slide? Thank you. So the Adolescent Health and Rights Program, which is a behavior change model focusing on sexual and reproductive health and rights, SRHR. So the very first version of the program was designed in the mid-1990s by World Renew and our partner SLDS, the Lutheran Services for Development in Senegal. The program uses behavior change communication through integration of peer education and a community-based approach. It was initially designed for a very specific group of adolescents, namely out-of-school girls aged 13 to 18, living in the poor suburbs of Dakar, the capital of Senegal. But it has continuously been updated to adjust to new developments in science, but also to new developments in the worlds of the adolescents that participate. The current curriculum in English and French is available for you if you'd like to use it to do either the full program or, for example, to use one or more lessons with groups you're already working with. Next slide. The Adolescent Health and Rights Program began as an HIV prevention program, but it was quickly expanded to cover other sexually transmitted infections. And following evaluations and sociological study, the curriculum was reworked to integrate a wider range of biblical justice topics that were important to the participants. You see on the right the full list of sessions in the English version of the curriculum as it's currently used in Nigeria, and it includes issues of early and unwanted marriage and pregnancy, nutrition, hygiene, healthy relationships with friends and also in romantic relationships, the prevention of sexual harassment and abuse, and what to do if this happens anyways to yourself or to someone you know. The program's last sessions are about the participants' role in their communities and how change can happen in communities. These sessions lead to an activity in the community to engage others and to help participants practice their newfound confidence. Next slide. So here you see the program's behavior change model, which is a socio-ecological model. It means with that we don't just teach individuals, but the model considers their place in the larger community and the interrelations between different groups of people. So you see on the left how What We're New, or our partner organization, trains peer educators. So in the white boxes. These peer educators are coached to find a group of participants in their own neighborhood who are taught using the curriculum we just discussed. This is a fixed curriculum. But of course, we have to recognize that these participants can't make decisions about their reproductive health all alone. Think, for example, about early marriage, a decision in which adolescent brides-to-be are hardly involved. And without this training, their objections would not even be heard. So the program involves parents and religious and community leaders in two ways. They participate in the discussion and learning sessions themselves, so they feel more confident and open to discuss with adolescents. And they're also invited to support their adolescent children or community members during community events and other activities. So there's direct behavior change communication with the adolescents aimed at achieving change in their knowledge, their attitudes, and their practice, as well as a community approach. And so these two support each other. Next slide. The program uses a peer education model. Peer education is built on the not at all revolutionary observation that adolescents are more willing to accept behavior change advice from someone that they consider a peer. In our cases, that's usually a woman who's a bit older, say early 20s, and has somewhat of an education so she can read the program materials and write simple reports. When doing behavior change communication with a group, a peer educator typically tries to identify from the different voices in the discussion those people who voice an opinion or a practice that the program wants to promote and supports those voices so they become more heard and accepted by the others, so that the whole group is guided towards a desired practice or attitude. The IMBR model of behavior change communication assumes that to adopt a new behavior and practice, someone needs 4 things, 4 aspects: information, motivation, behavioral skills, and resources, IMBR. Where possible, this program and its curriculum tries to integrate all of these. For example, by having participants make plans to act on their intentions expressed in the group, and by visiting the local clinic to make these more accessible. In the lessons, the program uses a lot of techniques known as adult education techniques, like group work, images, and skits. Through these teaching techniques, the program also gets to include pre-literacy training of girls who have never been to school and who learn to draw images and icons to present their ideas and often learn to use some letters. Next slide. As we saw in the program model earlier, the Adolescent Health and Rights Program involves direct peer education with adolescents, as well as involvement of the adults to create an environment conducive to behavior change. The curriculum is written with the idea in mind that adolescents are not independent individuals, but members of families and of communities. At the end of each lesson, participants not only summarize what they learned, but they discuss how and with whom they will share this once they get home. In interviews, many parents have told evaluators how much they appreciated this communication with their adolescent children, that they learned from it themselves, and that it convinced them to allow their child to continue going. The program works as a welcome conversation starter between children and parents, whereas in-depth communication between them is usually taboo. We have also collected several impact stories from sisters and friends who were told about the lessons from a participant, and who learned about program topics this way and adjusted their attitudes to, say, early marriage or girls' education. Next slide. As Christians, we believe that all people are children of God who have gifts that they should be welcome to use to contribute to their communities, and this includes out-of-school adolescents. In urban Senegalese culture, this is not what these girls are taught, but the program approaches them as responsible contributors to community life who are capable of making decisions. We have seen that once they show this ability, that parents are also proud of them and welcome this change. As mentioned previously, the curriculum ends with a number of sessions about the girls' place in their community and has them prepare a community event where they share one or more program lessons with their parents and religious and community leaders, and where the adults have the opportunity to show their support of the youth. Next slide. The program has evolved a lot since its beginning as an HIV prevention program in the 1990s, and it happened based on sociological research in the communities where our partner works. The research has shown us different challenges that our participants encounter and barriers they see in overcoming these problems. What Renew and SLDS regularly evaluate the program, including the aforementioned interviews with parents of participants. These have shown, for example, that as the girls gain confidence in expressing their objections to forced marriage, parents also become more willing to listen and in many cases allow their children to select their own spouse. Every year, we use the so-called beat game, here pictured, to measure impact of the program on participants' knowledge, their attitudes, and their behaviors. This beat game is an evaluation tool where each participant has green beads and red beads. A peer educator asks a question that is responded with yes, green, or no, red, and participants put the bead of their answer in a bag without showing others. When everyone has answered, the peer educator gets to count the yes and no answers. This way, participants get to answer anonymously to questions about sensitive topics. As we do this at the beginning and at the end of the program, we have a measure of impact of the program, even though we don't know the answer of each individual. Next slide. What Renew has used this program that was initially developed for a very particular group in Senegal in many different countries and situations. We've used it with sewing students in Niger, with church groups in Nigeria, and adolescents in Bangladesh. We've used it with groups of boys in schools, traveling cow herders, and oftentimes parents of adolescents and health workers have taken the role of peer educators. We've used single lessons or selections of lessons to teach parents and other community members. As World Renew and our partners, we love to share this resource with you. So if you think it may be of any use in your own program and community, please don't hesitate to ask us for it. Next slide. So you can request a curriculum in English or French through this email address on the slide, or I'm sure through the comments. Thank you for your attention.
Thank you so much, Esther, for being with us today and for sharing this really important and sometimes I think overlooked aspect of health system strengthening, and that's the community development work. I think it's really, really important, and I think the faith community has a great role to play in this. So thank you for sharing with us today. Greatly appreciate it. So we've wrapped up with our incredible list of panelists we've had today. As I said, I've never been a part of anything where there's been so many great speakers, and we want to leave plenty of time for questions. I know a lot of questions have come in. Some of them have been answered via the chat, and then we're going to answer some live here in just a few minutes. But before we go to those questions, keep typing them in. I want to spend a few minutes talking about another initiative that CCIH has started and a little bit about the why behind it. And that's the International Mapping Consortium. And for those of you that haven't heard of it, the goal is to map, maybe map isn't the word, but be able to quantify the work that y'all are doing, the work of the Christian community globally. This is beyond CCIH members. If you think about it, I always put my Doug hat on, I say, when I'm the leader of CCIH and people are asking you about what is the role of Christian healthcare here? What is the role of Christian healthcare here? And we always know it's significant. We know all this incredible work is going on, but how do we really tell the story well? And that is the purpose behind the Mapping Consortium. And I really appreciate Doug's leadership on this. And it's really a benefit for you as CCIH members too, along with the 30 by 30 initiative that they mentioned, which is a great benefit for CCIH members. I encourage everybody to learn more about that if you don't already and how you can participate, because it's a great benefit, but also this Mapping Consortium to be able to show the impact and scale and scope of the work you're doing. So Doug, I'm going to put you on the spot for just a second, because I know we have just a brief minute, but from your perspective, I want to just, if you could share just a little bit about the Mapping Consortium. I know our organization is a part of it because we're really passionate about it. There's a bunch of other amazing organizations that are a part of it. And just from your perspective, Doug, just a quick 1-minute synopsis of the Mapping Consortium, if that's possible.
Thanks, Barbara, really appreciate it. The Mapping Consortium was created by the Dalton Foundation in conjunction with the World Council of Churches, the International Christian Medical and Dental Association, the Africa Christian Health Association platform, and the Catholic Health Association of the US, along with CCIH, and CCIH serves as the secretariat. Our aim is to improve information about the scope and scale of Christian health assets around the world, not just health facilities, but also community and church-based health programs. So we're working together to improve the flow of information, which also means making efforts to improve the ability of local organizations to have their data be reflected up into national and global systems. So it's technical, it's a bit data focused, but it's also building the capacity, and we've already released one data brief out of that in partnership with IMA World Health and HAP that documented, for example, 8,300 health assets just in 16 countries in sub-Saharan Africa. It really is a new generation for us. Thanks, Barbara.
Thank you, Doug. And it is a really exciting initiative. Like I said, we all know that Christian healthcare plays a huge part in healthcare globally, maybe not always represented, I don't know, adequately at all healthcare discussions. But this is just a great attempt to really show what the Christian healthcare community is doing in healthcare. And I know we're really privileged to be a part of it. And we are going to turn it over to the questions now. I just want to give a quick synopsis of today. Like, I just love how CCH put this panelship together and how we touched on so many different important aspects of health system strengthening. You know, we started out with Dr. Smith, and again, I love the example of integrating our faith with our work. I don't know about y'all, but it's a constant struggle in keeping our identity in Christ. I love the way we started today with that, because I think that is the most important thing, to fix our eyes on Jesus, right? And we started talking about the use of technology and how to implement that. We went through workforce development, which touched on a lot of areas of leadership development, of educating the workforce, which is so important. And then we ended with the community efforts, which again is such an important part of the health system that sometimes is overlooked. So again, I just thought it was an excellent day. As I got to learn about it, I was really, really excited. So thank you everybody for participating. So again, keep asking your questions. I'm going to start asking a few of them that are in here. Our first question is for Lisa. Would you share more on the challenges in implementing this e-learning program at large scale in CHAM? I think in particular on the learners side.
Yes, thank you for that question. As we first started the implementation process, of course, we started small, and we did it with individual partner mission schools that we were working with and already had close relationships with. We are very fortunate in that one of our colleagues, Philemon Mulenga, who's with us and spoke with me today, has the close relationships with CHAM. CHAM oversees all of the Christian nursing schools in Malawi. So again, this takes it now to the broader scale countrywide reach that was possible. And working together was the way to start looking at what are those hurdles and how do we face those challenges to move forward and create it on a larger scale. I would say that challenges on the learner side, first of all, I think key to the successful implementation is a collaborative working relationship with a larger governing body. So that is very important, and having CHAM involved, and this is one of their key focus areas too. And really Malawi and the Higher Department of Education has said this is the most innovative platform coming into the country for education. So we have a lot of key stakeholders on board, and that has really alleviated most of the challenges we have. I think it's leadership and buy-in to create a successful platform, and that's helped us get over those challenges.
Thank you, Lisa. Can I ask a quick follow-up to that? Like, are you seeing any like literal technology challenges with just the internet and the hardware or anything like that that you've had to overcome?
Yes, we have. Maybe I'll leave that one to Philemon. I think he has a little bit more firsthand knowledge because he's actually on the ground there and he's lived that firsthand. Philemon, are you able to unmute and answer that question?
Lisa, I think he's frozen.
Okay, I'll go ahead and answer.
So we can come back.
Yes, I would answer that question, and yes, gadgets and devices are definitely an issue. The developing countries, Malawi, they just do not have, with the resources, limited resources. We see some schools that are outfitted better than others, but the age of technology, smartphones are present, and one of the important factors with this platform is that you are able to work off of a smartphone also. So it has an app capability. So that has been helpful. Despite the challenges with resources, our schools were highly driven and they made it happen. They got their content uploaded, they started enrolling the students and got students active with engagement on the platform. So challenges, yes, devices, resources is definitely an issue. And internet connectivity and appropriate bandwidth is also an issue. Trying to work with schools on how they prioritize funding, you know, and the capabilities. I did look as a needs assessment, looking at what other carriers were available, how do we upgrade services? But again, those have just been discussions at this point.
All right, thank you. Thank you for answering that.
I see that Philemon's back. I don't know if you want any other explanation, if Philemon has that opportunity.
Sure, go ahead, Philemon.
Thank you so much. I hope you can hear me now.
Yes.
All right. So as Lisa has already highlighted, we've had the challenges on the learner side, especially if you talk of the internet facilities. So in Malawi is one of the countries where we have unstable internet facilities and structures. So to curb such issues, we had to narrow down to the student initiative if they can manage. So most of the students that we are talking about here, we had learned the behavior of the system. So in the first place, the students, we had probably 10 less in a class of 60 students that had hand gadgets like their smartphones. So upon the initiation of the program, when they were coming in the second semester, when they had seen the importance of using the e-learning, we discovered that the number of the smart gadgets in the classroom had now increased in the number of the students to almost 3/4 of the class, like 90% of the students had acquired the gadgets. So with the use of the small gadgets, and then with the availability of subsidized data bundles, the students were able to purchase as a minimum bundle as they can, and Moodle is very much convenient with that. So they would have to get an assignment, and then they would just get the instructions, work offline, they would download the instructions, and then they would come up and just upload the whole activity. So this is how we have been trying to deal with an issue to do with the unstable internet and also increased cost of airtime charges that are here in the country.
Thank you so much, both Lisa and Philemon, for the great answers to those questions. And that's definitely one of the ones I had about challenges in implementing technology. I know that's one we face every day in our work as well. We're going to our next question. Our next question is from Dr. Nusser with Gilead. You have a long history of working to improve access to medications and have worked with faith communities. How can faith-based organizations work better and more effectively on pharma partnerships, kind of in general? And then specifically, can you expand on one area where you think Gilead would like to go deeper or farther with faith communities?
Okay, thank you. This is a very broad question, but I like it a lot. I have in my previous organization worked with faith-based organizations in Sub-Saharan Africa and now with Gilead as well. I see the faith-based organizations as a tremendous strength. A lot of facilities, a lot of capacities. Oftentimes, when we speak, for example, about meds as a distribution organization, they do testing, quality testing that many other distribution organizations wouldn't do. So also from a quality perspective, it's excellent to work with faith-based organizations. What is key when it comes to health system strengthening is to, from my perspective, look at what is the national plan, what is the national agenda, how can any organization or partnerships of several organizations link into a national plan so that solutions or perceived solutions aren't superimposed, but are really contributive. So co-creation and checking in with the government, what's key to them is important. And here the faith-based organizations are oftentimes very well connected with the government and can help inform when new partnerships are being formed about what's really important for the government.
All right, thank you so much. I always appreciate, I think, as faith-based organizations to hear, you know, how well we interact with companies like yours, what we can do better. I know that that's something that I know we always consider as well. So thank you for that answer. I really appreciate it. We're going to go on to our next question and comment. This is going to be for Esther. And there's a great comment made about amazing to see the difference that's been made in the last chart you presented based on the work you are doing. Congratulations on that for sure. And then the question, considering the Muslim context, what are the challenges you have encountered during the process, and how do you engage people in the discussion?
Yeah, thank you. Yeah, I think, I don't even know if it would really make a difference that this is a primarily Muslim community, talking about these very personal issues that touch on people's, not just their sexual lives, but their family lives when it's about marriage and having children, is sensitive, and so it gets to the core of who people are and how they organize their lives. So if you want to engender changes in how they do that and how they organize that, it comes with a lot of investment of time, discussion and openness to what people want themselves. But you also see that people often have done things a certain way but aren't happy about certain consequences of that. Like for us, the simplest example is always the early or forced marriage issue, which parents, especially for out-of-school girls, would continue to arrange, and yes, the girl never said anything about it, so it seemed fine. But they do see that it leads to more divorce, unhappiness for their daughter, to health issues for the children that are born to very young mothers. So just pointing at those issues and consequences and talking about that and suggesting that there may be other ways to do this. Usually people are quite open to that. But yeah, it does involve becoming part of the community. For us at World Renew, it's very important to work through partners, partner organizations who are always present in a community, who are from there. So those are ways to deal with that. But I know that there are other ways of approaching that to become a trusted member, part of the community, even if you do not work through a partnership model.
All right.
Does that answer your question?
Yeah, no,
Okay,
thank you.
thanks.
Thank you for answering. If the person who asked it, if they want to ask me follow-up questions, please feel free to do that in the chat.
Sure.
Definitely appreciate that. All right, so let's go on to our next question. This one is for Dr. Letchford and Diana. How long did the process take to get the tools for the technology in place and for people to learn how to use them and start using them in the clinic? And then an additional question along with that, how many staff in the clinic know how to use the technology? I think the real question, a good question, is how many people do you like train on when you install the technology?
Okay, yeah, great questions. I'm not sure if Diana's on. So Diana, if you're on, oh, there she is. Aha. So let me, Diana, do you want to speak first to how does it work in your clinic? How many people do you have using it? How long did it take them to learn how to use it? You can talk either about Mtego, Kawangware when you were there, whatever you'd like.
Thank you for the question. That is a very good question. All our staffs knows how to use the system. We have more than 10 people who have used the system so far. We have been using the system for quite a very long time, since 2018, and it has been of great help. Everybody knows how to use the system. It didn't take a very long time before we received the system. At first, we didn't have the internet, and we didn't have also the tools. When Banda came to register with us, so we had to look for computers, then we had to look also for internet. Then when we got the internet, It took like 2 days, then Banda came and installed for us. And since then, we have been using the system. We have moved from 3 places to where we are currently. And that is the system which we have been using, and it is working for us very nicely. And everybody knows how to use, because it is very easy to use. Even the cleaner who is in the facility can easily access, and Banda team are always ready for assistance in case there is anything to help.
All right. Dr. Letchford, do you have anything else to add?
Yeah, no, well, I could not have given, thank you, Diana. I'm not sure, part of the question is also how long did it take us to get to where Banda is now? I will just answer that if it wasn't there, but essentially the build, measure, learn that I mentioned, social innovation means you don't actually know what solution, you're not building an operating theater where we've done it a million times. There's very limited experience doing what we're doing in that particular market. And so it actually, this question of how to use technology, we looked with a few beta tests on a few different things until we realized this is the space that probably needed the impact. Once we did that, then Diana, when she started with what I would call a very Salesforce ugly version of what we had. It was very powerful, but it was very ugly on the front. But it was part of our minimum viable approach to it. So we gave, the early clinics started using something, and they told us with their words and with their actions what was working and what wasn't. And so what we have today is thanks to Diana and her staff and others saying, well, it would be easier if we could do this, or this is really what I needed to do. So yeah, so that's taken since 2018. That was the early version of what we're now doing is Banda Go. So, and it'll keep evolving every year or so.
Right. Thank you both so much for the answers. Really appreciate that. Our next question is for Father John in India. Because of COVID, what have been the biggest challenges to you in working on your 30 by 30 commitment? Is Father John still with us? Oh, you're muted, Father John. There we go.
Right? Am I audible?
Yes.
Yeah. So thank you, Barbara. I think world over, everybody faced the same challenges due to COVID situations. But we initially planned to have all the participants in one station and to give them a kind of classroom-based training, but that didn't work because they could not travel due to COVID restrictions. Also, we wanted to take them to hospitals where the systems are in place. And that also did not happen because traveling restrictions were there. We wanted also to send our interns to the facilities to give a hand-holding to the hospitals and the staff who are working in materials management to implement the systems in a better way. So that was one thing which we consider very important, because our plan was to identify 10 hospitals every year to give a hand-holding for them to implement the system properly. That is still in pipeline. We could do it in some of the locations where it was possible for us to travel, and systems were implemented, and we tried to help them to improve their quality also. Still, we look forward to get more of interns going to the field, because to teach them something theoretically so easy, especially when it comes to purchase, stores management, and so on. So it is a bit difficult for them to understand that easily, because they all are local people who come without any much of training in this line. So therefore, that was the major challenge we faced. And to understand the context from which they are talking also was a bit difficult, because India, as you all know, is a very diverse country with a lot of different languages, different cultures, different operational contexts. So therefore, we needed kind of realistic understanding of their context. which we hope in the near future we will be able to solve.
Thank you, Father John. We can only begin to imagine all the different complexities that come in with dealing with all the languages and throwing COVID on top of it. So thank you, and kudos to all you're doing to stay focused on your work. Our next question is for Sayona. You talked about the importance of communication and partnerships and working ahead. What would be the first step you think an organization should take to strengthen their supply chain today?
Thank you very much. So to strengthen communication, we need to recognize that collaboration with the suppliers and national supply chain is very important. And also one of the aspects that we have to do is to improve data collection. Data collection, collation, and aggregation, and also analysis of specific items that you need, and also management of stocks. So when improving communication, you need, first of all, to ensure that your database, in this case for the suppliers for the items that you need, is in place, because without that, you won't know where to start from. So you need, first of all, to collect information on the suppliers that you need to communicate to, first of all, and then also to establish links with those people, both physically and also online communication. Thank you.
Thank you so much, Sayona. I appreciate that. We've got so many good questions in here. I don't know if y'all can see them. I want to get to as many as we can in the next few minutes. Our next question is for Dr. Stevens in Sierra Leone. You shared in the video about the work you've done to strengthen your facility so far. What is your next step to keep strengthening your system?
Thank you very much. I'm very grateful for the opportunity we have to meet here as Christians and to share our faith and how we help our people and the people right across the globe. So Mercy, basically, we are catering not only for the inpatients we are taking care of. We are also having outreach clinics in and around Sierra Leone within the southern province, about 55 villages. We are giving out nutritional support, HIV counseling, free antenatal care clinic, and also in addition to other support we are giving to the community. So the things that we intend to do is how we can collaborate with the national program in Sierra Leone that cater for nutrition, because we are only providing nutrition to some villages within Sierra Leone. So on the globe as a whole, we are looking forward to how we can collaborate with the nationals, like the district health management team, how we can collaborate with them, and the very good project that only 55 villages are benefiting from, how we can spread out to the rest of Sierra Leone and some other places. And the better things that we are doing at the facilities also, we had a electronic database system that we tried a few months ago that is not presently working. But if we get this working, we can share this with the national health system that they can work with the electronic database system. So these are the things that we are working towards.
Great, thank you. Thank you for sharing that. Our next question is for Dr. Nunn, and this was actually one I had as well, so thank you for asking it. You left us with the cliffhanger question at the end of your presentation, and I'd love to hear your thoughts. What or how do you suggest we address the gaps in the training program for the residents on these soft skills? Because this is such a huge problem, I think, globally.
Hey, I'm sorry, I do appear to be having some problems with my internet connectivity and technical skills here this side. Please excuse me, I didn't hear your questions, but if I just answer the one that's come up on the chat, I believe probably the first step is likely to sort of lead me to actually asking the question, are the trainers actually trained in these soft skills? And certainly training the trainers, I think, is an important thing. I'm currently actually in Kenya on a train the trainer course with PACS at the moment. And I think there are a number of aspects that need to be covered, particularly ethics and whole person medicine came up as an important thing. Cure International has been developing a theology of disability course, which is an important thing to roll out. In terms of leadership and management, that's clearly a large gap as well. And I know that there are a number of generic courses, but it would be very nice to contextualize those to our setting. Thank you.
Okay, thank you, Dr. Nunn. Like I said, I know this topic is one that we work on a lot too, and I really appreciate your insights and work on this. I think we're going to try to just do one more question, and then we'll wrap up. I have a few. I want to ask one in here that I think is really good, and this one's for Esther. The comment and then the question, I love that you value the knowledge of the adolescents. I do think that's wonderful. And they share with their parents and community and religious leaders. That is a wonderful model. Can you talk about how long does it take to start? And number two, how long does it take to implement, to see behavior change? The real question being, how long does it take to actually see change like you've seen in your work?
I mean, the curriculum of peer education, I think the shortest one we have is 29 sessions. When someone wants to use the full curriculum. And so usually they try to do 2 sessions a week. So that would be about 4 months. So yeah, and with that you train like one group, or you can do several groups at the same time, obviously, to see the impact on wider society, to see it appropriated by parents, by other leaders in the community, by neighbors. That may take longer, but that very much depends on the girls themselves, but also just whether a community is ready for that, for those changes. And some communities pick up one message much more than the other, and next community may find something else in it that really speaks to them and that they implement very quickly. Yeah.
Thank you. Just hearing the number of sessions you do and how long they are, I think really does help to really like a practical example of how you're doing the work and leading to the change. So I think that can help, because I didn't have a concept of that. So thank you very much. And again, I want to thank everyone for being here today, both as participants and as this incredible panel. Just a lot of knowledge in a very short amount of time. And I really, again, thanks to CCIH and all the team behind the scenes. As you can probably imagine, this does takes a lot of work. So again, thank you, everybody. And now I want to turn it over to Mona, who is going to describe for us how to join the breakout rooms. This is the time where if we were all in person, we'd get to meet each other and chat and get to know a lot more details about each other's work, but we want to take advantage of these breakout rooms. So Mona, I'll turn it over to you.
Thanks so much, Barbara, for facilitating, and thank you to all of our amazing speakers. It's been a pleasure to be with you all today.